Welcome back, clinical problem solvers. Today we're going to tackle an important topic, visual field defects. I struggled understanding visual field defects for the longest time. We're hoping that we can simplify it so you feel confident when your patient complains of vision loss. And really, just giving you the punchline, it's really important to know how to localize the problem either to the eye, the optic nerve, the optic chiasm, or retrochiasmatic. In other words, is it the eye, is it the nerve, or is it the brain? Because that localization will help you with your differential diagnosis and the workup that you will ultimately send in your patient and the consultants that you will ultimately get for your patients. The most important step to make progress is to determine whether you're dealing with a single eye monocular vision loss or whether you have visual field defects in both eyes. The reason this is so helpful is because if it's a single eye, then you know the issue is either at the eye or the optic nerve. But if it's visual field defects in both eyes, then you know the lesion is in the brain. The ophthalmologist takes care of the eye, while the neurologist takes care of the optic nerve and the brain. There could be overlap though. An MRI is very helpful when you're trying to identify pathology in the brain or the optic nerve, while the ophthalmologist has a bunch of diagnostic tests they can do to evaluate vision loss that's in front of the eye, and they can also evaluate the optic nerve on their fundoscopic exam. And here we're going to show you a diagram where we identify the visual field deficit, but what you really have to practice is you identifying the visual field deficit in your patient. We don't do that test enough as internists, so I'd highly recommend you review resources. I'm going to look for a link of a video so you can actually practice the skill of being able to identify the visual field deficit, because it's by identifying the visual field deficit that you can then localize the site of pathology, which will then ultimately inform your differential diagnosis. We're going to go over the diagram pretty soon, but note this: left visual field defects in both eyes are a right brain problem. Right visual field defects in both eyes are a left brain problem. Superior visual field defects are an inferior brain problem. Inferior visual field defects are a superior brain problem. We're going to show this to you in the diagram where it all makes sense, but just know left is right, right is left, up is down, down is up. Basically, it's opposite of the visual field defect. Before we dive into the diagram, note if it's an eye issue leading to vision deficit, you just have to go through the anatomy of the eye. That's not going to be our focus here, but remember the anatomy of the eye includes the cornea, the lens, the vitreous, the retina. But if it's an optic nerve issue, we know we're dealing with monocular vision loss. This is where you incorporate the time course. So we identified the visual field deficit being one eye. We also determined that we're not dealing with an eye issue, but rather we're dealing with an optic nerve issue. Once you make that determination, then you have to use the time course, which will influence your differential diagnosis. So if it's sudden in onset, usually sudden means some kind of vascular catastrophe. So this can be ischemic neuropathy that you might see in patients with vascular risk factors or giant cell arteritis. If it's acute in onset, meaning occurring over hours to days, then you're more likely dealing with inflammation of the optic nerve. This has a specific term known as optic neuritis, and causes include multiple sclerosis or infections like Bartonella. But if you're dealing with a subacute process, then it's more likely to be compression from a neoplasm. Or it could be a toxic metabolic process like B12 deficiency or methanol intoxication. And chronic causes can be genetic stuff that can lead to optic nerve disease. All right, let's jump right into the diagram now. I really love this diagram. We'll provide a link below for you to access it. But here it is, visual field defects. And we said it's a 3-step process. Identify the visual field loss. So you have to be able to know how to do visual field loss. Step 2, localize the site of lesion, and then let that localization with the time course get you to the DDX. And just big picture here, the left visual field is always going to hit the right side of both eyes and end up in the right brain, while the right visual field is going to hit the left side of both eyes and always end up in the left brain, the occipital lobe, the visual cortex. So we already talked about monocular vision loss. This is bitemporal hemianopia. Why is it called hemianopia? Hemi just means half. Anopia means without vision. So when we say hemianopia, we're saying half of the visual field is gone. And bitemporal, we're talking about temporal side, not medial, but temporal. So bitemporal hemianopia, if you can identify that in your patient, you've localized a chiasmatic lesion, and usually it's due to a mass like a neoplasm. And this was our whole left is right, right is left, up is down, down is up. And so anytime you're dealing with a homonymous hemianopia or any of the quadrantanopia, then we know that we're dealing with a retrochiasmatic lesion. For homonymous hemianopia, what this means is, remember we said half the vision, no vision in half the field. Homonymous means basically the same side. So here you can see it's the left side of both eyes. So this is left-sided homonymous hemianopia. And if you diagnose that, then the lesion is either at the optic tract. You see, left visual field defect means right. So it's either at the right optic tract or the lateral geniculate nucleus, or it's at both optic radiation. So you're taking out both the superior and the inferior, or the lesion is in the occipital cortex. But if someone is having superior quadrantanopia, hard word to pronounce, quadrant means a single quadrant without vision, and superior means the upper visual field. And it's going to be the same side. We don't end up saying homonymous superior quadrantanopia because it's going to always be the same side. Then you know if it's superior visual field defect, it has to be an issue with the inferior radiation. But if it's inferior, then it has to be an issue with the superior radiation. And once you identify a retrochiasmatic lesion, then you can use the time course to make progress. Sudden onset, a vascular issue like a stroke. Acute in onset, you're really dealing with infections and inflammatory / demyelinating conditions. Subacute, neoplasms, and chronic could be degeneration. So just one last view of this beautiful figure. Identify the visual field loss, localize the lesion, and then using time course, come up with the most relevant DDX. In summary, what's most important is to determine, are you dealing with one eye or both eyes? To do this, you need to examine each eye separately. And the reason this matters is because you want to know, are you calling the ophthalmologist and having them do their standard test? Or are you getting an MRI because you're concerned with an optic nerve issue or a brain issue? No, we're talking about visual field loss. We're not talking about blurred vision. That's important. This is not blurred vision talk. This is the visual field talk.